I am Valentin Fuster, Editor-in-Chief of the Journal of the American College of Cardiology, past President of the American Heart Association, and Director of the Mount Sinai Heart Center here in New York. It's really a pleasure to have this meeting today and talk about cardiovascular health. I am speaking on behalf of the American College of Cardiology, and I am very grateful to this fantastic organization to give us the chance to talk about so important subject. So let's start. What is the title of the subject? Well, the title, I like the mission of the American College of Cardiology, and that is to transform cardiovascular care, improve heart health. See, let's just move on with the mission of the American College of Cardiology. And now it's a pleasure to introduce people who actually have been in this field of health, epidemiology, and so forth for many years, and they all have been real experts into what we are going to discuss today. Again, I want to thank the American College of Cardiology by picking up these people who are going to have discussion with us today. Let me introduce them. Dr. Mpiko Ntsekhe is the Helen and Morris Moorburger Professor of Cardiology and at University of Cape Town, and he is also the Pascal Vice President for the Southern Africa. Thank you very much to be with us today. Thank you, I appreciate it. Then we have here Dr. Yuling Hong, who is the Chief of the Epidemiology Branch at the Division of Cardiovascular Sciences at NHLBI in Bethesda, Maryland. And he was Associate Director for Science in the Division for Heart Disease and Stroke Prevention at the CDC. And then we have here Yvo Smulders, who is the Professor of Internal Medicine at the Amsterdam University Medical Center, and he chaired the Vascular Medicine Training Program in Amsterdam for 10 years. So Dr. Hong and Dr. Smulders, thank you very much to be with us today. Well, we are going to have a very dynamic discussion. I'd like to divide this session in 4 different parts. First, what is going on in the United States? Because there is an alarm system. Then what is going on in the world? And, you know, population is increasing, people are aging more and more, risk factor profile continues to be not good. So let's see what happens in the world. Then we are going to make predictions. What is going to happen in the next 2 or 3 decades, knowing what is happening today? And finally, what are we going to do? How can we help today the #1 killer, which is cardiovascular disease, meaning myocardial infarction and stroke? So we are going to be, again, very dynamic, short questions, short answers, and I'd like to start with what I consider is an alarm, a warning. Let me present the data in the United States as it has been portrayed, actually, Dr. Hong by the NHLBI, very recent publication. And this is the story. In the United States, cardiovascular disease mortality has significantly decreased between 1990 and 2010. New medications, defibrillators, pacemakers, and so forth. We all know this story. Great. Now let me tell you what's happening between 2010 and 2018. Good. It is now a plateau and it begins to go up. And the question is because we have more population, is because the population is aging, or because risk factors? So I want to start with Dr. Ntsekhe about what is your feeling, and I am just presenting only United States. Do you think it's an alarm system, the fact that we are now reaching a plateau and maybe mortality is increasing?
Very much so. I think you've got a part of the geography that clearly is the wealthiest in the world. They've had all the data, they've got all the resources. They've had, I think, quite successful policy implementation as a general rule. They've had all the drug interventions that you've spoken about. And we've seen great successes. And yet, as you say, in this last decade, not only has they plateaued, but I think the graphs are starting to head up in the wrong direction. All right. Now, of course, for me, that is a huge alarm bell. In what sense? I mean, if it's happening there, we really, I think, have to unpack and understand what the issues are, because it's got huge implications for environments like us that are so far behind, so to speak, on the curveball with regard to all the successful interventions. So whether it is, yeah.
I'd like to ask actually, Dr. Hong, I would like to ask you a question. Do you think that this is the problem with increased mortality, at least in the United States, is because the population is increasing? Do you think it's because people are aging? Or do you think it's because the risk factor profile is increasing?
Yes, thank you. And thank you for the opportunity to present my view here. I think that for mortality, as we know, that divided by two factors. One is that the prevalence and the morbidity, and also treatment and care. As you indicate that really over the past decades, I think the treatment has improved, but the risk factor that has really kind of not declined and increased. If we look at it back to the history a little bit longer, since 1960, in the United States, the mortality has declined significantly, but it has increased, as you indicated, since 2010. And all the risk factors, I think some are doing better, but some, like tobacco smoking, used to be very high, but now I think it kind of stable, a little bit increase. For blood hypertension is still high, and the control of hypertension rate is very low. And the aging is not really a factor here, because when we reported the mortality, it's based on age standardized. So I think that we can do more about the risk factors. And
thank you. We'll get into this in a moment. Let me now introduce Dr. Michael Pratt. Thank you very much to be with us today. Dr. Pratt is a professor and the director of the Institute for Public Health and the Master of Public Health program at the University of California, San Diego. And he's also the chair of the Global Observatory for Physical Activity. Thanks to be with us today, Dr. Pratt.
Thank you, Dr. Fuster. A real pleasure to join such an eminent group and to have been part of this GPD project. So I'm really happy to be here as I sip my morning coffee.
Thank you very much. Dr. Smulders, about the topic that we are talking about, the United States, are you worried about what is happening?
Yeah, certainly am, and I agree with the previous speakers that some of it is real, and the consequence of increased risk factor prevalence. I am wondering, though, if perhaps part of the increased mortality, or the plateauing at least, is delayed mortality, because the main gain has been in the acute survival, in the acute care of myocardial infarction. And obviously, if we keep those patients alive more and more, 10, 15 years ago, we are now seeing maybe some delayed mortality because, for example, of ischemic heart failure, because we are doing such a good job in taking care of acute myocardial infarction. Just wondering if that explains some of the things we're seeing now.
I have to congratulate you, Dr. Smulders, because in Europe things are much better. In fact, we will be discussing this in a moment. This is why I pointed out the United States, because things don't look here good enough. Let's now move to the world. So actually, when we go to the figures, and we publish these the Institute of Health Metrics, Dr. Roth and actually Dr. Mensah from NHLBI, and me as editor of JACC, we published this recently. Actually, mortality as a whole has increased all over the world between 1990 and 2019. And this is very important because when we go to other parts of the world, we cannot say mortality has significantly decreased over the last 2 decades and now is beginning to increase. In fact, it's the opposite. And actually, I have the figures here. And from China and from India particularly, and from the Russian Federation, actually the mortality has progressively increased since 1990. So, Dr. Hong, this actually, I work with Dr. Mensah from your institution, NHLBI, on this paper. It seems to me that United States, the problem is now, but in the world has been for a long time.
Yeah, yeah, I think like India, China, I think we have seen that increase, and also in last year you mentioned, and the same with sub-Saharan Africa, and their stroke rate is extremely high. Yeah, so the lesson learned from us, I guess, from older years, 60 and on, and I think we have some successful story, but look like that. In this country mentioned above, we say that even the care has improved, but the risk factor has increased for cardiovascular disease.
Thank you, Dr. Pratt. Let me tell you now, we had 3 possibilities by what things are not going in the right direction at this time. One possibility that we discuss is the increasing population over the last 3 decades. The other possibility is people are aging, as it has been discussed previously, and the other is the risk factor profile. Well, we have interesting data, again, that was published recently, and that is not the overall mortality of cardiovascular disease around the world. Now we can say per 100,000 population, so we can take the possibility of increased population out. Well, actually, the data suggests that both aging and the increase in risk factors are actually playing a role, Dr. Pratt. Is this your perception?
Yeah, I think this is an interesting discussion, and it's certainly possible that the whole complex of risk factors may have not progressed at the same rate that it was in previous decades, when probably this was really driven by, in many countries, very substantial improvements in blood pressure control and lowering cholesterol and tobacco. Now we're faced with the risk factors that we have much more trouble dealing with. Physical activity is generally flat. We have been good at reducing physical activity in a few places, but overall across the world, while the data is not great, it suggests that there's been very little change, so not much progress. Diet is much the same. We have a lot of trouble making these sort of complex changes. And one of the things that may be impinging on the situation in the US, which we're referring to as the deaths of despair issue that people have raised, not specifically with cardiovascular disease, but if we are having more mental health troubles, more problems with alcoholism, these things may be part of that overall complex of poor health behaviors that could be influencing things. So I think no longer having the substantial improvements in risk factor profile that we did in previous decades could be part of what's going on.
Thank you very much, Dr. Pratt. Actually, this data is interesting, and again, was published with my colleagues at NHLBI in the Institute of Health Metrics, and that is what has really increased significantly is the body mass index, that is obesity. And with obesity, the data is goes along with diabetes, so diabetes goes along with obesity, and that's the second issue. And as mentioned, other things have been stable. Tobacco is slightly decreased, but the real thing is that there's an increase, as mentioned, in the aging of the population, but at the same time, obesity is also increasing at the same time. So I think these are the worries, isn't it? Obesity and diabetes and hypertension, perhaps.
Right. So, the area obviously that I've been focusing most is in sub-Saharan Africa, and that constellation that you just described is becoming a major problem. I think, as Dr. Pratt is saying, some of the things that are influencing the non-traditional, we see violence across the continent and political instability, insecurity being a major issue. And why is that important? Because it has an impact on physical activity. It has an impact on people's ability to be gainfully employed in physical labor like they used to be. So there's big rural, urban, and other types of migration around the continent. And all of these things, I think, are coming together. And we're seeing it really in this constellation of BMI, diabetes, hypertension, the mental health disorders. And I should say again for our region that we talk about an epidemiological transition. We like to view it here as multimorbidity. I'm not too sure that we have gotten rid of the TB and HIV and some of those things that are also accelerating some of these the atherogenesis of this risk factor or the impact on these traditional risk factors on cardiovascular disease incidence and prevalence. So
thank you very much. It seems we are a little bit pessimistic, Dr. Smulders, but we have to be. Let me tell you something and see how you explain why about 5 years ago a number of cardiovascular organizations said by the year 2020 we will have a decrease of 30% of cardiovascular mortality, and now we are hearing by 2025 we'll have a 30% decrease in mortality, and the mortality keeps increasing. What is wrong here? Are the people telling us something that is absolutely false and we believe on? Or tell me what is happening, because it's a real paradox.
Well, I've never seen the sort of underlying proof or data supporting such a claim that you could expect a 30% decrease. I was not expecting an increase, but certainly not that degree of a decrease, certainly not worldwide. I think urbanization is a big issue in, for example, the African and South American continent, and the obesity epidemic, again, the delayed mortality because of improved care of acute MI. I mean, there are several factors that wouldn't justify that degree of optimism. So I think that was simply overly optimistic. We haven't been put back 30% compared to 5 years ago. The 30% estimate was very, very optimistic, in my opinion.
So it seems to me, Dr. Smulders, that in fact this was a wish, actually, from these organizations. We should achieve this and that, rather than based on the data. But this is the fact that we are a little bit in the pessimistic side. We'll have hope in a moment, but it's because people should understand what is happening, rather than just talking in a way that is basically nonsense. Dr. Pratt, what do you think about these projections and what is happening?
Well, I think we've covered some of the issues, and these are probably based on the tremendous progress that was made in the 60s and 70s, and various, American Heart Association and various other organizations could look at these and think, wow, we're much more advanced technologically, but as has been pointed out, a lot of the big improvements in cardiac care, in risk factor profiles had already occurred, and projecting them to occur in the global South, where, as it's also been pointed out, there's much more complicated situations and fewer resources, and people are going through complicated epidemiologic transitions, probably not realistic. And then the other factor, it's again we touched on, we're left with physical activity, diet, obesity, and diabetes, which are all closely interrelated and combined have a very big impact on cardiovascular disease mortality. And if we struggle to make progress in those in a comparable way to the way we brought down smoking rates, we're not going to see huge reductions in mortality. So yes, I think these were somewhat fanciful projections based on a high degree of optimism and not really grounded in the pragmatic reality of both a changing world and complicated health behaviors that are not easy to alter.
Thank you. And now Dr. Hong and Dr. Smulders, things are somewhat different, for example, in Japan and in that part of the world in East Asia, where in fact mortality continues to decrease. And then for Dr. Smulders from Europe, actually things look much better than we have discussed. So Dr. Hong, why do you think that in certain geographic areas, like, for example, Japan, things are continue to be very positive? And then I will ask the same question about Europe to Dr. Smulders.
I think that it was discussed earlier that the obesity and diabetes coupled with hypertension, I think in Japan and maybe not representative of all East Asian and Europe, I think that the obesity situation in Europe is better. So I think that might explain the difference. And yes, 30% kind of goal decline is audacious goal, and does not reflect the trends in risk factors.
Thank you, Dr. Smulders. About Europe?
Yeah. Well, in Europe, the obesity rates are increasing at a slower rate, I think, than in the US. Smoking rates are extremely low. There's a very aggressive anti-tobacco lobby, but I can be pessimistic too. I mean, in terms of epidemiology, we often have a lag time between what happens in the States and what happens in Europe of 5 to 10 years. So maybe we'll be seeing the same phenomena in Europe in 5 to 10 years. I can't be really sure.
Thank you. So let's now project to the future. And this is actually based on the data just came out from the NHANES organization here in the United States. And they projected the diabetes, hypertension, obesity, myocardial infarction, and so forth. We'll go over these 225 to 260. And this is a statistical game, obviously. You take many factors together, and then you try to project. And the question here is that when you look at hypertension and diabetes, the prediction in the United States is between 225 and 260 is going to increase by 25%. The question is, obviously, this is very worrisome. The question is, this can be in part by increasing population, although this is a very short window, but by aging population or by the risk factor profile. This is with diabetes and hypertension. This was just published. With obesity, 30% increase. With dyslipidemia, 15%. And then they go into myocardial infarction and stroke, an increase of about 15 to 20%. This is the projections that are made for going from 225 to 260. And obviously, this is very worrisome, which will lead to the most important part of our discussion today, that we'll see how do we manage all of this. Dr. Ntsekhe, do you feel, how do you feel about this information?
Right. Yes, it's very alarming. Yes, it's very worrying. I think one of the something we haven't quite spoken about again is the impact of knowledge and information and the sophisticated data and access to data that we have now that perhaps wasn't as accurate some time ago. And where it provides me with some optimism is it allows for opportunity to intervene. So yes, it might be that these projections are in line with what we're seeing now, but will those projections be realized? Perhaps not. And I know we're going to talk about what potential interventions are. I'm optimistic in the sense that I think it gives us the opportunity to actually think very carefully about possible interventions and how we can stem the tide so that those projections aren't realized.
So, Dr. Pratt, is what we are talking about in the projections of the future are a motivation that we should do something about it? Tell us what you think.
Yes, I think it obviously is. These are dire predictions. And as just pointed out, our record on these kind of projections is not so good. We've just been looking at the fact that we had overly optimistic projections, granted not necessarily all data-based, and now we have some very pessimistic ones. So yes, it should motivate us to take some of the risk factor changes very seriously. And we really do need to start looking, as I think we're going to get to in our discussion, at upstream approaches to changing risk behavior. So these are the sort of policy interventions that might allow coupling approaches to climate change mitigation with improved infrastructure for active transport, something that could be very important for getting more people to be more physically active in many countries around the world. Perhaps using some of the approaches that have been used over the last few decades in Europe for incentivizing healthier diets and with rebalancing agricultural subsidies. So I think we have to think big picture upstream policy impacts on health behaviors. And then the other area that is ripe for better intervention is improved approaches to addressing diet, physical activity, obesity, and diabetes within primary care, where we've always done this, but we have never been terribly effective at counseling, referral, systematic approaches to behavior change that are really supported across the whole breadth of the medical system and out into the community. And where we may get a little bit of extra push for this, I think, is that it's pretty clear that all these factors we've mentioned are very important for future pandemic prevention and resilience of the population. And that's a place where health systems are willing to invest very heavily in avoiding the disaster that we faced with COVID, and cardiovascular disease prevention, diabetes prevention, dealing with the health behavior risk factors are a big part of that.
Thank you, Dr. Pratt. Dr. Smulders, so we are facing a situation here that we have to do something about it, and we will discuss this in a few minutes, but the problem that I see is a world of consumption, a world of competition, a world that really makes us to move into the opposite direction into what we are doing or what we are talking about. And we should do something about it. But do you think we will be able to overcome this, or it will be mandatory, or from governments and so forth? How do you see, in general terms, we might be able to do something about it?
Well, we're obviously facing a lifestyle crisis, which is basically what we're talking about. And I do agree with Dr. Pratt that we can expect some effect of the policy interventions, portion size, redesigning the public space to nudge people to be more active. I tend to be a little bit more pessimistic on individual approaches, counseling, lifestyle programs for people at risk. I've been reviewing the literature recently, and it's striking how intense these programs can be and how little effect they have on lifestyle and even on clinical outcomes. So very pessimistic about changing behavior based on individual approach, certainly more optimistic on policy interventions, yeah.
Thank you, Dr. Hong. I would present a different point of view. I agree with what Dr. Smulders said, but I have a view, and we will discuss this in a moment. We should develop a culture from the bottom up. Really saying is education, children, school systems, family, and so forth, rather than from the top down. I think both, we will discuss both in a moment, but I'd like you to see if you have a sense that we should do a lot from the bottom up.
Yeah, well, I think it can be both, and I agree that individual approach alone is not enough. I would suggest that kind of 3D approach, community and settings. You mentioned a school and also kind of churches and healthcare facility, workplace, and with different risk factors, and come up with kind of different interventions. And I would say that it's kind of position public health. And so I think different locations and the different population, with different approaches, both individual and population and community level approach.
Well, thank you. This leads us to what I consider is the most important part of our discussion today, and that is what can we do? Now, and I'm going to present to you a hypothesis, and Dr. Ntsekhe, before we discuss each aspect of the hypothesis, I'd like if you are in agreement with. We have three populations here. Again, it's a hypothesis. One population is middle age, let's say between age 20 to 60. Another population between age 60 to 100, and another population between birth and age 20. The reason I'm presenting this to you is because I have a sense, and the data is becoming very obvious in the literature, that the approach is completely different depending on the age of the population that you are dealing with. Are you in agreement with that before we go into the details of these age groups?
I would be aligned with that hypothesis. I think it's a fair hypothesis. Yes. The impact of your interventions will be different, and the opportunities per these different populations would be different. I would agree.
Thank you. Dr. Hong, see if you are in agreement with. Between age 20 to 60, we are dealing about cardiovascular disease. And I asked you, what is the main challenge? And I said to you, one possibility that I know if I have arterial disease or not, which is the #1 killer. And if I know, I'm going to change my lifestyle. So I only present to you, do you think the main challenge is to know if we are developing the disease? Is not an important challenge that may make us to act?
Yeah, I think that that's both. I think that really, for the young adult, the challenge is that need more education. Yeah, I think first of all, they need to know that, they have the condition or subclinical condition. And then based on enhance, for example, hypertension control in the younger adult from 18 to 39 is much, much lower than the elderly adult. I think that they may be aware of that, and they thought they will be okay.
Yeah.
And they may have insurance, but they did not utilize. I think that education, is important, not just for the school kids, but for the young adult. I think it's more important than the elderly adult.
Well, we'll get into education because you are so right, Dr. Hong. We'll get this in a moment. Dr. Smulders, you are a real expert in vascular disease. And I'd like to ask you a question. And that is, we all talk about risk factors. And you may be a smoker. And I will tell you, you have a 50%, I know you are not, but let's assume you are. You have a 50% chance to develop a heart attack, but you have a 50% chance of not developing it. Why we don't look at imaging technology? If we find an economic technology to look at your arteries, and if your arteries are showing us the disease, I think there means this is the highest risk factor. I'd like you to react to the issue of imaging.
Well, I think this has a lot to do with risk communication and how risk communication affects behavior. And there have been several studies looking at how indicators of early stage disease influence risk perception and subsequently risk behavior. And it's not always favorable. If you are a pessimistic type and someone is telling me you already have disease, it doesn't necessarily make me comply with lifestyle recommendations. I might think, well, it's too late anyway, let's enjoy life. So now the latest data seem to suggest that on average, people tend to adhere a bit better to lifestyle recommendations if they, for example, get a coronary calcium score, but the effects are diverse and some people become more pessimistic. So we need to find strategies on how to communicate risk in what is most effective in terms of getting people to change their lifestyle. And it's not a straightforward answer, I think.
You are quite correct, Dr. Smulders. You may show the arteries to an individual, to a patient, and may say, and so what? And this answers the issue of education in time to say what that means. Well, I'd like to go for a moment into data that is evolving very rapidly, certainly from us and others, and we are using ultrasound of the carotids, iliofemorals, and main aorta. And one of the issues is when you go to the guidelines are all based on risk factors from certain age 40, 50, Framingham 10 years, 30 years, and so forth. But what we are finding is quite striking, and that is you have subclinical disease much earlier. And in fact, an LDL cholesterol that we consider normal of 80, 90, 100, we find that there is subclinical disease unless it's less than 60. The same with prediabetes, or and the same we found with hypertension and triglycerides. So my question is, before we go into more detail, should we just make people aware that the guidelines are really based data that is at this moment is somewhat archaic? Dr. Pratt.
Well, Dr. Fuster, you've touched on the classic challenge of guidelines, which are almost always set at a particular point, versus science, which usually follows a typical biological curve. There's no single point at which LDL cholesterol goes from safe to dangerous. There's no single point at which diastolic blood pressure passes from okay to not okay. And there's no single number of minutes of physical activity, which is the critical break point between sufficient and insufficient and sufficient. And so, yeah, this is an existential problem for public health in particular, because we want simple guidelines that people can understand. Yet science is not simple and it doesn't stay the same. So I think for clinicians, the more we can get to distal measures rather than very proximal ones. Coronary calcium is a better indicator than blood levels of LDL, for example. The better we can fine-tune our clinical care. So yeah, I think we have to update guidelines, but it's probably unrealistic to think that more complicated communication with the public is going to make our job easier. It could put us in the situation that we tend to be with diet, where people go, oh, they change these guidelines every 5 years. I used to think I couldn't eat any fat. Now it seems like it's better than sugar and so forth. And the science changes in sophisticated and gradual ways, but the guidelines, communicating that to the public is never easy. And so I'm not sure that we should have so much emphasis on the public's guidelines. Rather, we should try to shift practice. And this is besides the fact that it's really probably the big upstream factors that are key determinants for long-term success.
Dr. Pratt, I am in agreement with you, but there is some point that I'd like Dr. Ntsekhe to talk about. It's not the guideline what tell you what LDL cholesterol level you should begin to give statins. But the guideline says you start looking at you at age 40, 50 and see what happened when in fact everything is lost before. And the question is, all the guidelines are based on heart attacks, strokes, and then you go backwards and you divide, then you get age 40, 50. But let me tell you, in ultrasound, the disease begins at age 20, 25, and begins actually in the legs, in the iliofemoral region. And even you don't have to go to calcification, because calcification of the arteries comes later. And look at the cardiac study. The cardiac study that you know well, actually between age 20 and 40, these people who had risk factors, and you look at the area, what happened in the 20 to 40 and how the various levels of cholesterol are, and then you get a composition 20, 40 years later, and this is just published, you can predict cardiovascular events to what the risk factor profile was between age 20 and 30. So this goes to Dr. Ntsekhe, and that is, I agree with Dr. Pratt completely about his point about guidelines, but what I'm saying is when to start to look at things. And subclinical disease is telling us that we have to start much earlier. That's all what I'm saying, rather than giving a guideline of what to do. What do you think?
So again, as with many of the things you posted, as a very complex environment, I think a upstream look that takes a lifespan approach is most appropriate. Okay, and as you've done in your modeling about the different populations, I think there's a lot of good to be done the earlier we start, whether it's with health education, whether it's with behavior change in the young that hopefully start early, modifying the things that we can modify, obesity, diet, etc. My big problem with the use of things like ultrasound and imaging, etc., is the following. We've just painted a picture where 80% of cardiovascular disease occurs in the global south, where those guidelines actually are a fantasy in many instances. It's tough enough to so the emphasis really is, let's increase the awareness about these things, perhaps reframe the disease concept. We talk about risk factors versus disease. If you've got obesity, diabetes, and hypertension, isn't that a disease? Should we not be, why do we have to show the atherosclerosis before we want to trigger the messaging that says intervene? So I would definitely agree with Dr. Pratt, but in all this conversation about where science and technology and guidelines come together, I'm also very cognizant of the fact that in low and low middle income countries, many of the some of the technology and the diagnostic tools that we might want to use to guide treatment are going to make it harder for us to actually get the job done, is what I would suggest.
Thank you. Dr. Hong, you probably know, because I'm working with some of your colleagues in poor countries, and let me tell you what we do, and I'm just for the discussion here. We do ultrasound only of the iliofemoral region, because that's where the disease begins. And we don't take blood. What we do, we look at all the risk factors, obesity and exercise and so forth, and we assume indirectly about glucose and cholesterol. And in a matter of minutes, actually, half an hour, you really have a full profile. The question is what you do then. But what I'm saying is, we can go to countries with economically, they cannot afford this is technology of ultrasound that we have is just very economic, very cheap actually. But what I'm saying is we should be able to go to low-income countries and start much earlier. This is really what the point I'm trying to get across here, rather than even talking about guidelines at age 40, 50. So I'd like you to react to this possibility. Dr.
Well,
Hong.
I think that, sorry, yeah, am I on? Can you hear me?
Yeah.
Yeah, so I think it is very important for ischemic, atherosclerotic conditions. You need to start earlier. And for the guideline, it's different from the clinical practice guideline. It's more like prevention guideline. And in the US, US Prevent Task Force, and you have to weigh the benefit and harm and the most cost-effective way. I think the cost is a factor, not just in the sub-Saharan African countries, other, lower middle income countries. Is a factor in the United States and the high income country as well. But as you said, that if we can substantially lower the cost, and then cost is a not factor, I think it's really a good way to do. And some of the imaging tests now getting cheaper and cheaper. But I think that maybe, when the subclinical condition, you don't have a treatment, but at least motivate individual to start with lifestyle intervention. I think that's the most important step. And in some countries, I think China, like they did some echo for the coronary wall sickness kind of things already started. I think the leadership and the government, put that a priority. That will be important. I think different countries, different system is different, but early intervention, obviously, detection and intervention, it's going to be key, I guess, for the cardiovascular disease prevention.
Thank you, Dr. Pratt. We talk about age 20 to 60, and we are all in agreement that it's difficult, but we should start earlier. And then the question is education and so forth. But there is an issue here that is evolving very rapidly in the literature, and you are aware of. All the risk factors we mentioned are affecting the elderly people with cognitive function. In other words, the data is evolving very rapidly. How hypertension not being treated plays a role in dementia, vascular dementia, even the acceleration of Alzheimer's. So what I'm really asking you is, maybe those of us who are in the cardiovascular field, we think a lot about the heart and the coronary arteries and so forth, but the thing that worries me is things that are silent and start at young age may affect your head, your brain later on in life. And to me, that's the challenge in older ages. So I like to focus our attention in something that maybe we don't pay enough attention, which is your brain.
Yeah, I think this is a great point. It's one, as a public health person, this has always been an interesting conundrum to me, that mental health and cognitive function are one of the most important underlying issues for burden of disease. Not as easy to point to for mortality, but for morbidity, they're huge. And this is true very much in older adults, but you can see impacts, for example, of physical activity on cognitive function, on measures of brain activity in adolescence. And we know very well that physical activity is one of the protective factors for Alzheimer's and other diseases of dementia in older adults. So I think the bigger issue is that for both clinical medicine and public health, we tend to think of mental health and cognitive function as that's something somebody else does. That's not a core public health thing. That's not what we cardiologists do. That's the neurologists or the gerontologists. And in fact, they're closely related. And so, yes, we need to pay much more attention to cognitive function. And we really need to be thinking about this across the age span, because in some sense, the same issue that we've just been talking about of preclinical disease exists for sure in late middle age, well before the actual true dysfunction of dementia occurs. So yeah, really a really important point, both from a policy standpoint, more emphasis on public health and mental health, and from a clinical standpoint, better integration of our services.
Thank you. Dr. Smulders, I just had experience recently, and that is, and you had the same experience. Patients come to you. You say you have to lose weight, you have to stop smoking, you have to do exercise, and the patient tells, well, you are a torture doctor. I want to die suddenly, and don't bother me. I mean, this has been discussed already. But I noticed something. If you tell these patients, what about your brain? Your brain can slowly, your memory, and this is not dying suddenly. What do you think? And I found a tremendous impact. I don't know what they are going to do afterwards, but one thing I can tell you, what I am finding is society is much more sensitized today to the brain than to the heart. And if you go to the to these patients and you talk about the brain, they are very, very worried. And I'm asking you because perhaps we as cardiologists, I am a cardiologist, we should begin to talk about the brain rather than the heart. So that's my question to you.
You raise a very interesting point. I never tried it, I must admit. Been trying some things also in studies on how to communicate risk, and we're slowly moving to time gained in good health. So what extra life years or months do I add in terms of a healthy life? But I've never tried the cognitive issue. One of the things is that the cognition issue is only weakly related to, for example, your lipid profile, but it's much more strongly related to your blood pressure. This is one reason why I tend to not accept high normal grade 1 hypertension in middle-aged or even young subjects, whereas I am a little bit more lenient on lipid targets, particularly because of this effect it has on brain health in later in life. But again, I haven't tried it, so you may well be right.
Thank you very much. Dr. Ntsekhe, we have talked about an integration of science, epidemiology, aging, but what about young people? What about from birth to age 20? The only reason I'm asking this because there's another parameter here that is not science, is education. And I think you will agree, but neuroscience is telling us something very important, that whatever we learn between age 3 and age 10, we have a number of centers in the brain, not too many. You capture what you hear, and then later on in life it comes out. And if we all look at how we are today, there's no question the environment that we had at that age was important. So the question is why we don't try to infuse health as a priority in our children in terms of whether this can be having an impact at older age. And I only will tell you the two findings of this. We are working actually with 50,000 children around the world, and we found two things that are very interesting. One is bad news, and that is when you follow these children that you spend 60 hours of teaching them about health, when they are 5-6 years later, they forget about it. But there is something else. If you reintervene, then you have an exponential effect. So basically, what we are learning is that whatever we do in life, and when you start early, the most important thing is not once, but several times. But there's a second finding, the control group. In the school systems we have been working with, Sesame Street, you might know the school systems that we have worked with, the control groups do very well, also short term, because they are in an environment that talks about health. So what we are learning is intervention many times, or every 5 years or so. And then the environment where you are, to have an environment of health, are probably two critical issues that we have to pay attention to. And I like how you react to it.
No, I think excellent points you're making. It reminds me, I mean, there's similar studies for language, I mean, as a model. So kids that grow up in an environment where they are exposed to a language or learn a language might forget the language because they move to another country or whatever. But later in life, when they're exposed to the same language, obviously they might learn it much easier than those that never had exposure to the language before. So I think there's some consistency in terms of what you're saying there, and a very, very important reminder. There are a lot of pessimists about the impact of trying to inculcate culture and behavior change, and that the earlier you start, the better. I think, the examples you're giving are very important, whether it's direct education, modeling, within the family, within the community, in schools, etc. So my reaction actually is I'm not surprised by the data you've just given us, and I think again it's a very encouraging target for us to aim for when we're talking about these upstream targets for intervention.
Thank you very much, Dr. Hong. I love when you talk about education. This was your first statement today. And this is really what we are talking about, is that is the importance of education. And earlier we start better. But let me tell you something, Dr. Hong. When we saw the control people, children, that they were acting better in an environment of health, that we didn't intervene, we moved to the family. Because the school, you're there individual, but the family is the whole environment. Do you think that perhaps, and we have a project now, and we get into the families, actually, parents, children, and grandchildren. Do you think we should pay more attention to a culture that begins with the family, and then they help each other in this educational approach? I'm just asking you.
Yeah, education, I think the other thing is health communication, right? Now the information is exploding, and accurate information is very important, I think, in the social media. And family is very important. I think the culture difference, right, in the countries, and in US and Europe and other countries is very different. And even in Europe, in Italian or Spanish community will be different from the West and Northern Europe. I guess that you can do some, kind of studies in this family-oriented countries, and then see how that will work. Maybe just one comment. I think you mentioned that the cardio, maybe it's better for the audience to know what the cardio means. Cardio is coronary artery risk development in young studies. It was supported by NHBI, and the study started in 1985 and 86. At baseline, the age is 18 to 35. Now they're in the mid-60s.
Yeah, thank you. And I think the results of the cardiac that are coming out now are fantastic. The risk factors that were very significant at young age are now giving heart attacks and strokes, and the opposite. When the profile was low at young age, you see a significant decrease in the events later on. Now, this leads to the question, Dr. Pratt, should we work in our environment more? For example, I go to Madrid almost every week because we have the Center of Research there, and we have 400 investigators. Should we get into that environment and begin to work in terms of health in a community basis, knowing that how important the environment is, and really begin to pay attention to that? What do you think, Dr. Pratt?
Yes, I certainly agree with that approach. I'm a public health person, so I like to look at upstream factors. And I think what really points this out is we've been discussing how challenging it is to change health behaviors, how some of the population trends are going in the wrong way. What's hidden by this is that in all of the higher resource countries, and even lower resource countries where there are pockets of high resources, people do quite well. And the United States is the extreme example of this, where we have lots of inequity, and we have county by county mortality rates, and you see a variation basically from equivalent of Japan to the equivalent of Bangladesh. And this is all about the greater social determinants of health: education, economics, lack of poverty, access to health care, outlook on life, really mental health, and what impacts these environments and policies. And yes, and it even impacts those of us who are already privileged. I spent last year as a visiting scholar in the Czech Republic. I didn't drive a car for a year, walked everywhere. I'm already skinny, but I lost another 5 kilos just because I'm out on the street walking absolutely everywhere. And so yes, environment is hugely important, and subtly changing it has the potential, particularly, I think, as we've discussed with younger individuals, to give them a healthier start on life and perhaps to prepare them for healthier choices later in life. So yes, and it's incumbent upon our governments to recognize this and to have policies that help us invest in better access to open space, better access to good food, better access to health care, less poverty for everyone across all parts of the population, not just those of us who happen to have privileged existences.
Quite in agreement, Dr. Smulders. We are getting into the end of this discussion, and here comes the issue that we presented before, and that is, how do we work from the bottom up or from the top to the bottom? From the bottom up is education, children, family, environment, and from the top down, you can certainly have a tremendous impact on the environment from the government point of view. I think, frankly, that over the years, if you really look what has been done, aside of the medications and the defibrillators and so forth that have been so helpful, I think that we lack this bottom up, and we all expect that from the top things will come to the bottom. It's not your perception? Perhaps we are missing the bottom up, I would say.
Yeah, I fully agree. I mean, 20 to 60 range is quite wide, and I do think there are possibilities between, for example, 20 and 30. It's about programming people towards a healthy lifestyle. I mean, we are doing a bad job in reprogramming adults to adopt a healthier lifestyle. I think we can certainly do a better job in programming youths for a healthy life. And in that respect, I agree with Dr. Pratt that the policy interventions and the environment, and I also believe in role models, for example, give us a lot of opportunity in that respect. The family-based interventions seem to be a little bit less effective because they require to reprogram the parents' convictions about healthy lifestyle. There's been a trial in England where lifestyle intervention based on educating parents was very ineffective. So yeah, I do think we need to do a better job bottom up, and it's all about programming, policy intervention, nudging, role models, etc.
Dr. Ntsekhe, we are going to finish now, and I would like to say that actually from the bottom up that we are talking about that perhaps is missing, if you do the education at the same time in the family, that is the parents and the children, it seems working, at least in our experience, but it's very difficult to educate the parents independently. It has to be with the family. But having said that, I would like you to give a summary of what we discussed today and to tell what should we do based on everything that we have discussed. I'd like to hear from you.
Right. No, thanks. Thanks for the opportunity to wrap things up. It's been a wonderful session. Excellent insights. I think people have brought their experience and perspectives in a nice way. In terms of summary, I'll just speak to what I have learned. I think we focused quite a bit on some worrying global trends in terms of burden, in terms of mortality, in terms of risk factor burden. We've looked at the United States, where it seems like there was first a plateau and things have gone up, and then around the globe, certainly in the global south, where all the trajectories are in the wrong direction. They're not accounted for just by age. They do seem to be accounted for by changes in in risk factor profile, as we've indicated, and these are worrying trends. And the question really is, what's driving it? And what are the possibilities for how we can intervene? And I think, again, there we've emphasized looking at many of the upstream factors. I think that's been a recurring theme, i.e., how do we impact the environment? How do we impact behavior change? And recognizing that sometimes changing things at an individual level might be much harder, but possible. With regard to how we change things at the environment, again, I think there's been some nice discussion around that, or within this. Do we do impact of bottom-up approaches to top-down approaches? Where does policy come into that equation versus, and then looking at things like education, in particular in the young, and how do you deliver that in education? How do you package health messaging so that it has a lifelong impact? When do you start it? Should we divide our populations really into much younger, under 20, where we have different approaches for them, to those that are much older, to the middle group here who might be set in their ways and require slightly different health interventions? We've looked at this whole lifespan of the population and the trends of both risk factors and disease within them, what's driving these changes around the globe. Something perhaps I feel that we might not have emphasized enough here is the issue of health inequity and its impact on our ability to change all of this, because I think it is very, 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 very important, particularly as you look at north-south gradients of disease and within country gradients across sort of social measures of education and wealth. So to summarize that's really what I've taken away from much of the discussion here, and I've enjoyed the hour, I must say.
Thank you very much. Dr. Hong, you talk about communication, and Dr. Ntsekhe really mentioned that. I think it's critical, isn't it?
Yeah, I think that on one hand, we don't have enough information, but sometimes we have too much information, and in the media, I think we really need to help the public to understand better the big picture, the whole picture. If I may, I think that maybe just point a couple of things not related to communication, but we didn't discuss today. And on the trends of non-ischemic nature of cardiovascular disease has increased much more than the ischemic or atherosclerotic heart disease. But I'm not going to expand on that. I think we need to pay attention. The sleep cause that, and heart failure, for example, not from ischemic heart disease. And the other thing, I think you mentioned the pollution, air pollution, some of the not traditional risk factor, pollution, heavy metal, lead, and also lead and arsenic and other heavy metals, and etc. Thank you.
Thank you. A final word, Dr. Smulders.
Well, no final words from me. I think both previous speakers did an excellent wrap-up. It was a very inspiring session. One remark maybe is that education is a very cognitive way of approaching this, which is not always effective. I think there's a lot in subconscious nudging of particularly young individuals. Again, the role of young role models is very important. So we need to really use all the methods we have to get youngsters to adopt a healthier lifestyle.
Thank you, Dr. Smulders. Dr. Pratt.
Well, first, Dr. Fuster, thanks for the chance to be part of this webinar. Really fascinating discussion, and I enjoyed being part of it. And it reminds me of how important it is to have both clinical and public health approaches. They are very complementary, and the dynamics, some of the dynamics are very consistent. Some of the things we've been talking about were important for changing cardiovascular disease mortality in Finland back in the 60s and 70s, but there are also technologic advances that play into this. And so, for example, the idea that we might replace traditional laboratory measures with a quick field ultrasound is exactly the kind of disruptive technology that could be really important for not just clinical, but public health approaches. So thanks a lot for the chance to be part of this. And I will need to sign off to jump on another teleconference. So I really enjoyed this. Thank you.
Well, thank you very much. It was wonderful. And certainly, just for the audience, this is a discussion among real experts in the field. And I feel very honored to be with you today and to have had this discussion. I want to take this opportunity again to thank very much the American College of Cardiology for giving us this opportunity. Thank you all. Thanks.